I think so. I'd like to welcome everyone. Good morning, everyone. My name is Gail Nixick with ElderWorks Educational Services. I'm very pleased this morning to be joined with our co-host, CJE Senior Life and Peer Services. So just a little bit about ElderWorks Educational Services. We are a non-for-profit located in Palatine. What we do is we help individuals when they're looking for care options for older and disabled adults, whether that is to remain in their home safely or to transition them to a community. Another arm of what we do is certainly help people with resources in terms of out in the community. We have a wonderful directory that has all the different services available throughout the Illinois area. Please feel free to reach out to me if you'd like a copy of our recent directory. And of course, we are providing the education both for professionals and consumers ongoing. If you're not on our weekly email list, please let me know, and I'm happy to add you to our email so you can get some notices on education coming up. At this point, I would love to introduce Sharon Dornberg-Lee, who is going to be fielding a lot of the questions. As she mentioned that we are using the Q&A for that. So I'm going to turn it over to you. Thank you again, Sharon, and welcome.
Thank you so much, Gail, and it's a pleasure to partner with ElderWorks as always to bring this training to you. I am Sharon Dornberg-Lee, as Gail said. I am the Clinical Director of Community Services at CJE Senior Life, and we want to welcome you to our program today, Substance Use Disorders and Older Adults. I have just a few things to mention very briefly, a little housekeeping before we get started and I introduce today's speaker. Today's program is co-sponsored by CJE Senior Life, ElderWorks, and also Jewish Child and Family Services. So very briefly about CJE. For over 50 years, we've offered services to older adults and family caregivers, including adult day services, care management, health and wellness programs, and mental health services, to name just a few. We're now offering two newer therapy groups, cognitive behavioral therapy for depression and anxiety, and another therapy group for those with chronic pain. We're also pleased to offer PEARLS, one-on-one short-term evidence-based treatment for depression. So I wanted to highlight those services. If anybody wants to know more, you can always contact us about any of our services through our intake team at 773-508-1000. Our other sponsor today is JCFS Chicago, and JCFS Addiction Services offers community education, professional training, and support to Chicago's Jewish community on addiction-related issues. So thank you, JCFS Chicago, for being our co-sponsor. You're going to hear a lot more about peer services from Christine, but first the housekeeping items. There will be 2 free CEUs awarded for today's program if you need them, and you'll be prompted to complete an evaluation at the end of today's program. You'll receive instructions on receiving your CEUs along with today's slides from the presentation via email. Please do be aware that this program is being recorded, and we encourage you to use the Q&A feature at the bottom of your screen to ask questions of the speakers. In this format of a webinar, please don't use the raise hand feature because unfortunately we can't see you. And the chat feature has been disabled. So please use that Q&A button at the bottom to participate and interact with us. We'll be taking questions, Christine will at the end, and I'll try to monitor the Q&A as we go forward in case there's anything that's important to address sooner rather than later. Finally, before I introduce Christine, I wanted to mention that to view the closed captioning of today's event, you'll need to turn this feature on manually on your device. We can't turn it on, you need to. And you can do this by selecting the CC live transcript icon at the bottom of your screen. Now it's my privilege to introduce our speaker today, Christine McCall of Peer Services. Christine is a licensed clinical social worker and also a certified alcohol and drug counselor. She developed and oversees the adult and adolescent treatment intensive outpatient program and aftercare program at Peer Services. And she also oversees Peer's early intervention, individual and group counseling, medicated assisted treatment, and dual diagnosis programs. Is that all, Christine? She's also an experienced trainer and leads community presentations around substance use and mental health. Prior to her work with Peer Services, Christine provided clinical case management and therapy to individuals with dual diagnoses in a supportive housing program, in addition to linking them with stable housing opportunities in Chicago. I always love to hear that people have a care management background. I know that that serves you well in the work that you do now. So without further ado, welcome Christine McCall of Peer Services, and thank you for being here. I'm going to turn off my camera, but I'll be there looking at the Q&A.
Okay, great. Wonderful. Thank you. Thank you, Sharon. Thank you, everyone. I always get very uncomfortable listening to my own bio. Which was a little outdated. I'm going to share a little bit more about myself and why particularly I've come into the field. Welcome. I do, it takes me a little bit to get used to a webinar type of training. I typically love doing more in person, but I understand that it's just sometimes more convenient for folks. So bear with me. Sharon, I do encourage if there's a question that comes up through, interrupt me so we can get those answered in real time, so that people feel like they're not having to wait for their questions answered, and we'll see how this goes. All right, so I'll talk a little bit about Peer Services, and I think rather than our, just going into the mission vision, talking about our values and how we uphold them. So Peer Services has been around for almost 50 years. We are a small community-based nonprofit located. Our brick and mortar is located in Evanston. And we also have a facility that is, we rent space out of Turning Point, Skokie, but we have shifted and done, especially since COVID, did a lot of community-based programming. So I'll talk about that in the next slide, kind of what we offer, what we do, and what our thoughts are. But our mission is reducing the harms of substance use, addiction, stigma by engaging youth and adults with innovative prevention programming and supporting those on their path to recovery through holistic, evidence-based treatment. So our values were person-centered, and we're rooted in harm reduction philosophies. So we're going to meet you where you're at in your recovery process. We understand it's not linear, it's a continuum. And the most important thing is engagement. So if we can encourage that client to reach any sense of well-being or reduced harm, we're gonna start there. Not to be confused with, I think some people, when they hear harm reduction, they assume that means that we don't incorporate 12 steps or absence-based models. We 100% do. If a client is coming to our services and they are heavily involved in 12 steps, it works for them. I love nothing more than that. And so we're just really encouraging and offering all the different options for the client so that they can make the best decision for themselves in their recovery. We're trauma informed. All of our therapists are master's level and have had extensive training on mental health and trauma. As we know, with substance use, there's a high proponent of clients that are also dealing with long-term complex trauma. And one of our values is being holistic. We incorporate lots of different modalities in our practices, including art therapy and other type of expressive therapies to help, address other things that are going on. I think one of my favorite quotes is one of our clients who's engaging, an older adult client who's engaged in art therapy group. He said, I just don't want to only be talking about my triggers, right? Because you can only talk about that so often. So some of our expressive therapies programs allow clients to build skills, to build confidence that will help in the recovery. And they're not only talking about triggers and other kind of traditional substance use treatment methods. Okay, so specifically our services, again, we are located in Evanston and Skokie at a turning point. We have no official catchment area, so we can serve anyone anywhere that's able to get to us. We really do prioritize Evanston, of course, and other North Shore communities and townships, including Skokie, Winnetka, Glencoe, and Glenview. But we also see a lot of clients from North Chicago, and even some of our clients, it says far reaching of South Chicago, because they started coming here, they really like the services and they wanted to continue here. So the specific services we offer, so we offer medication assisted recovery, otherwise known as MAR. I'll be referring to that in this presentation. What that is medications that supplement the therapy counseling, group counseling that we already do. Currently, we offer methadone for clients who are opioid dependent. We are very shortly, I would think this next month, very excited about it, going to be offering buprenorphine. That's also a medication that helps with opioid related dependence, and Vivitrol. And Vivitrol it can be used with OUD, opioid use disorders, but it has to be after their completion of treatment. What Vivitrol is mostly known for is for helping people with alcohol use disorders. I'll talk a little bit more about Vivitrol and how this can be really helpful for older adults, and why it's a great medication to help with meeting people with where they're at in their alcohol recovery. So that's one of our programs. That is what most people know us about. It's why we were created in 1975. Evanston saw the response of Vietnam War vets coming back and being addicted to opioids. So in the response to that, they wanted a community-based nonprofit to help its residents. And therefore, Peer Services started with methadone for the vets. Since then, we've obviously grown, but that is kind of where our core started from. Other than our MAR program, and again, with that program, all master's levels clients, clinicians, along with a full nursing team and medical director. We offer individual therapy, group therapy, case management, art therapy, anything that client may need to help in their recovery path. And we have actually a lot of older adults in that program that I'll talk more about throughout my presentation. Our other outpatient non-MAR offerings are individual psychotherapy for adults, adolescents, adults, older adults, and family members. We offer intensive outpatient group treatment for adults and older adults, our aftercare group treatment, and DUI risk education, alcohol and drug evaluations, and prevention. So with all of these services, what we noticed, it was funny during COVID, our referrals really just plummeted. People, and I'm sure that maybe people on this webinar also noticed that in their setting, people were really struggling, and it wasn't a great time to want to make healthy choices for yourself, right? Because everyone was just surviving. And we know that, especially the statistics now, that many people were surviving and dealing with the trauma with alcohol, with other drugs. So now, I guess since about 2021, we started seeing people come back. We started seeing people who had been isolating for a couple of years who really wanting help. We also noticed that people were really struggling to actually come on site for services in the same way they did pre-COVID. So what we have shifted in our thinking is how we offer community-based services. We do telehealth, but we know telehealth is not always effective for all populations. And so we've started partnering with other nonprofits, other community areas to offer on-site services for their clients in the community. We also will be part of the Evanston Living Room that's going to be opening hopefully in the winter in partnership with Turning Point and Impact. And so all that being said, I think the direction where we're going and where we're seeing the need is that meeting clients where they're at, even demographically, is so important right now. Okay, I know I only have 2 hours, so I have to make sure I'm not getting into many tangents. Again, so I'm Christine, and this is who we are. I like to show this picture of our staff. This is from our Step Up for Recovery fundraiser last year, because this is a really good capture of who we are in our staff. We are a small nonprofit, but we work really hard, and we really want to make a big impact in the communities we serve. I should also mention that one of our values is that we do not deny anybody based on financial inability to pay. We accept Medicaid, Medicare, no insurance. There should not be that barrier for people to receive treatment. So we will work with anyone and everyone, regardless. I got into this field. I got my master's from Loyola, and with a focus on mental health and substance use. I always knew I wanted to work in substance use, not because I have a history of being in addiction or because I have a family member who is. Of course, I've been touched personally and with my family with the continuum. But really what was motivating for me is that I was always very perplexed why we are treating something as complex, biologically, socially, like addiction, with the most simplistic models. And so even now, we have not great research about what treatments work, what addiction is, who's affected, what are risk factors. We have theories and we're getting there, but compared to other diseases, addiction treatment really is behind. And I do think that's because of the stigma still that exists. So I really wanted to dedicate a good portion of my career to helping people, of which other people really didn't want to help because it's complicated and it's really hard. I came into older adults kind of accidentally. When I started working at Peer, my predecessor, Fran Schnoddick, which I'm sure some of you know on the webinar, was very passionate about older adult care and substance use, and we have a specialized older adult program. And in starting to work with older adults, I realized that this is an even more vulnerable population, of which either clinicians really don't want to work with, or they don't want to ask the questions of, they don't feel like they can ask the questions about if their older adult client is using drugs or alcohol. And then if they know it, it's really scary. So now I don't want to deal with it. And so I really saw this population as really struggling, really needing help, and just wanting someone to listen to them and understand them and to be seen as the full, capable, whole person that they are. So that's how I got into working with older adults. Substance use was intentional, older adults was by accident. But I love both parts. Okay, so my trainings, if anyone has ever been on them, I really encourage a lot of reflection. I think part of the work that we do, I'm going to offer lots of content and concrete information, but a lot of this stuff is really about tapping into your own feelings and biases around substance use in older adults. So I encourage that throughout. If we were in person, we would do a little more interaction, but because we're not, I'm still going to ask everyone to take a few minutes to think through a couple of these questions. And I think it's helpful if you write them down, put them on paper, put them in front of you to reflect back after the presentation. So question 1. How do you think about substance use disorders or addiction? What's the first thing that comes to your mind when you think of someone that is addicted? Question 2, when thinking about asking your older adult client about substance use, what is your first reaction? I want you to write that down immediately. Don't give too much thought. What does it feel like to ask your client, how much do you drink? And if anyone, I would love if people that are feeling able to share, if you can share these with Sharon that we can kind of reflect on in the end. I'd really appreciate it, so we can kind of get some initial thoughts about this. And finally, what resources, supports do you need to feel prepared to screen, identify, and help your older adult with substance use disorders? So I'm going to give about 1 minute to write down these questions. For those that feel that want and are able to share, please do share this so that we can have this as our ongoing conversation.
And just to be clear, Christine, do you want people to put it in the Q&A if they feel comfortable doing so? That's where I would be able to see it.
Yes, please.
Okay, great.
Thank you.
I'm actually not able to participate as a panelist in the Q&A, so I'll just say, I know what comes to mind for me is like, ugh, like a sense of dread that this is going to be hard, that I'm going to be worried about this person, that they may be defensive. So that's what goes on for me, and to be really honest.
Thank you. Absolutely. I mean, I still feel those things because it is hard, and so much comes up with this personally. Especially with older adults, when maybe there is, an age difference, right? There is some transference that may be happening with yourself and the client. So thank you, and I definitely can relate.
Absolutely.
Okay. Right. I'm going to just respond with or share what we've seen here. My concern is linking patients with older adult resources for SUD is there's limited resources. Absolutely. We're going to talk a little bit about that later.
And Christine, so sorry to interrupt, but we're getting some black boxes on your screen. You probably
I'm
can't
sorry.
see them. I think
go.
when you move your cursor, that's great. Thanks.
Okay. All right. Thank you. Great. Thank you for your Q&A. Thank you for participating. Some objectives for today. So I'm going to give a brief overview, Substance Use 101. Some of you may have, more or less experience with substance use. I'll give you kind of the basics and what to look out for, and specifically implications for older adults. We're going to talk about what to look for, how to appropriately, accurately screen, assess, and refer. We're going to talk about best practices for engaging older adults in the conversation. And then I'm going to wrap up with referral options and resources. And we'll take about a little bit of a break around 9:30, because I know 2 hours of a webinar is it's a lot. Okay, so first, let's talk about definitions. But what I do want to draw attention to first is look at these images on your screen. They're pretty horrifying, right? You see a skull, a needle, drugs, someone snorting drugs. You see someone passed out with pills and a noose around someone's hands praying. I didn't choose these because I like these. What I did is I went into Google and I just typed in addiction, and I wanted to pull the first kind of images I saw. So I share these, even though they're upsetting and triggering, because even today, this is what this is what a lot of people think about with addiction, right? The stigma that exists, and why people may not want to disclose that they're struggling. And so I think this is always important to keep in mind as we continue this. So talking about the definitions, there's a lot, people think of addiction in a lot of different ways. There's a misconception that like, well, if I'm not waking up drinking, then I'm not addicted. If I'm, if people that think of addiction as people homeless on the street. But as we know, it's a continuum. So I wanted to offer a couple of definitions that I really like, that I think really do capture what this is without bias and judgment. So the American Society of Addiction Medicine, otherwise known as ASAM, defines addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. DSM-5 is a little more concise, is substance use disorder, is the recurrent use of alcohol or drugs that cause significant impairment or distress. And then the DSM-5 goes into the different levels, and I will review that later on. And then NIDA, which is the National Institute of Drug Abuse, is defined as chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. So I share these because even with, the people, the organizations that dedicate their mission towards addiction, we still have many different definitions. I personally really like the ASAM definition best, because I think it addresses how complex this is, and that it's not so clear cut as, my dad was an alcoholic, therefore I will be. So use what's helpful here, but it's important when we think about and talk with our clients that we give them the accurate information of what the definitions are, because they could be struggling, but think that because, again, they're not waking up using drugs or alcohol, that they don't have a problem of some sort. Okay, so I'm going to talk a little bit about the brain and why why this is so complicated, but important to know. So with the brain,
So sorry to interrupt again. We're still getting a little bit of a black box on the very top that's covering some of the words. I don't know if you can just try to slide your mouse away, if that would help.
Well, it's the screen where the says where you're sharing the screen, and it has that little.
Oh, I think you can just drag that away with your cursor.
Oh, can I?
Try that. So sorry,
there we
everybody.
Go. Does it work?
No, we're still.
No.
Oh, now it's moved down. So yeah, move it down a little bit more if you can. Keep dragging it right out of the way.
Sorry, everyone.
That's okay. Usually that doesn't show up on the screen. I'm not sure why that's happening for you.
Not either.
But just drag that as low as you can drag it to get it completely
that's
up.
The lowest I can
that's the lowest.
Yeah.
What about trying to drag it way up and away, and then we'll just have to live with it?
No, that's as much as I can do. Drag it.
Okay, I think we'll live with it. We're sorry, folks.
Okay. Yeah, you'd think by this time we would have all mastered this, but that's not true. So thank you for your I'll try to drag it down for the content that we can see. Okay, so with the brain, we know that the brain does keep growing and evolving till 25 or even extend that. So when we're dealing with older adults, the brain is developed at that point. But it is important to understand how this affects the developing brain, because if you are working with an older adult that started using at an early age, they could have made real brain changes that they're still dealing with. So with we have a cerebral cortex, which is our self-awareness, our impulsivity, our logic, and our judgment. And so this is our more mature brain, right? It's where we make decisions that are healthy for ourselves. We know not to, make impulsive decisions. It's what is developed when we get into our, mid to late 20s. The limbic system, that's more of our flight or fight, our animalistic response, right? It controls the pleasure, reward, threat response system. And so this is our immature, or a baby brain, if you will. And so this is where, when you're younger, right, like as an adolescent, as a child, you're not able to utilize the judgment, the more mature part of the brain, which is why, and the effect with substances is when you use substances, it gets into that limbic part of the brain. And so the problem that if, for instance, when people start using drugs very early, drugs and alcohol, they have an immediate pleasure response, right? Like they have a dopamine rush. Oh, wow, that felt really great. And they're, let's just say 15. They don't have the judgment able to tell them that, like, maybe I shouldn't have this. Maybe it's going to be bad for me. Maybe it's going to impact my future. They just have like a dopamine hit and it feels real good. The problem is the more that you use, especially in early age, these circuits, these pathways are created so that your brain knows, okay, if I want to feel good, if I want to get that dopamine rush, I need to use this thing. And the more that we strengthen pathways early on, the more they connect. What also happens, and what this is important to know about dopamine, is that your body, your brain needs to constantly recalibrate. So it can't be flooded with large amounts of dopamine all the time, because obviously that would not be good for it. So what happens is if your brain starts understanding that, oh, we're using this substance every day, I better slow down my body's natural ability to produce dopamine. So it produces less. So the things that you used to feel gave you pleasure, maybe meeting with a friend, watching a game, whatever used to give you that kind of natural high, no longer does it for you. So therefore, the individual might start using more drugs and alcohol because they realize that I don't feel good. I want to feel better. And this is how I know how to feel better. And this is a really important part of the cycle of addiction, and this kind of a really dangerous cycle. And then what happens when you have a longer term addiction is that your brain doesn't have your limbic, you weren't able to fully develop that judgment part of your brain in regards to substances, and it's constantly bypassing that and going to the limbic system. So that's why cravings are so dangerous and hard, because you get hit and hit and hit, but it's bypassing that judgment. So even before your brain is able to say, you know what, I can't do that, this isn't good for me, it's affecting my relationships, you're already finding where that next fix will be. And so I share this not because we're talking about younger people today, but I share this because if you're, I think it's important to understand why it's so hard to stop using drugs and alcohol. And also, if you're working with an older adult who has been using substances for a long time, education around this is really important and can help reduce shame. Because if you started, many of our older adult clients in our MAR program started using heroin at a very young age, and they've been in our program for 20, 30 years successfully on methadone, and they're stable. But they still are seated with a lot of shame about why they still have cravings, why maybe they had a relapse. How can I be a 60-year-old person and still struggle with this? What's wrong with me? And so it's really important to explain that this is actually physiological, out of their control. We have a choice in how we respond to that, the treatment we get, the supports we get, and the tools we learn, but so much of that is under control. And I think it's important to make sure that message is being shared with older adults who are struggling. Let me move this little black box up there now. Okay. So implications for older adults. What we know that substance use and overuse is not great for everyone, but for older adults, why it's particularly concerning. I do want to start out that in the research, every article I go through, everything starts with still not a lot of research is known about the impacts of older adults' brains and substances. So there really isn't a ton of useful information. There's not a lot of people studying this. We can talk about kind of the stigma and bias that may affect that. But this is what we know so far. So we know that as we age, our bodies, our metabolism slows down. We know that particularly substances, it takes longer to metabolize those substances. So if we're drinking the same amount at 72 as we were drinking at 30, we're going to be affected way more because our liver is not processing the same amount of alcohol as it was. So we know that there's because of this, right? We know there's an increased risk for car accidents and falls. If older adults are using the same way that they once did, they're just going to be more impaired quicker. And so they need to be mindful of putting in some, utilizing some harm reduction strategies to minimize the risks of falls and car accidents and other accidents due to being impaired. We know that chronic health conditions and medications can increase potency of substances. It's important to understand what the older adult, what medications are taking and what health conditions they have, so that you can make informed decisions on what's best for them. For instance, if an older adult is struggling with dementia, right, that can be really dangerous with substance use and their medications, if they're not having a caretaker managing their medications, excuse me, which then leads into accidental misuse of prescription medications and mixing. I think it's important not just if a client, if you notice your client is running out of their medications, it's important to kind of check in to make sure that they're not assuming that they're purposely overusing, but are they accidentally misusing their prescription medications, and particularly being mindful that they know that there are counterindications and dangerous implications if they're mixing certain medications with drugs or alcohol. Misuse of prescriptions by caregiver. This is also something, unfortunately, we do see. So, having, when you're with a client with a caregiver, ensuring that, just being mindful of that being on the radar of making sure that your client is getting the medication that they need. If you start noticing things that are different, just something to explore a little bit, because, unfortunately, we have seen that. And then this is something that I think we see, and we are seeing more of, is ever since the start of the opioid epidemic, of the underprescribing for pain. We've had, so there was a client in our MAR program who has been successfully on methadone for a long time and doing well. They had to have an operation that's very painful, and the physician refused. They did not prescribe any narcotics post-op for this client, even though the operation was very painful and very hard to recover, because of their history of use. Which I understand the logic and reasoning. However, that is putting that, rather than giving the client a couple of, prescription or a couple of pills to help them through that acute pain, that's causing them more possibility to relapse and find some pain meds on the street. So as a caseworker and as a counselor, I think being an advocate for your client, if they are in pain and they are being underprescribed, really working with that physician, offering education, because, we all deserve to have a pain limited experience, and older adults typically just struggle with it a little bit more. Excuse me. And there's evidence from this with patients with addiction histories are at risk of are at increased risk of receiving inadequate pain management due to healthcare providers' lack of knowledge about treating patients with addiction and fears of exacerbating addiction. So, unfortunately, we have swung in the opposite way in some ways of not being able to offer appropriate pain management for people. This is an interesting study and statistic that I have some conflicting thoughts about, but I wanted to share that as among dementia patients who initiated their first opioid prescription, 33% died with 180 days compared to 6.4 without an opioid prescription. So at first glance of this, you're like, wow, like we shouldn't prescribe opioids to people with dementia because they died. 33% of them died versus 6 without it. But I don't really think that's really capturing a lot of the important stuff we need. I would just like to know more about this study, because I think studies like this can create bias towards physicians not prescribing really important and necessary pain medication to clients. And I think that there is also this age bias, like, well, they're older, they're in dementia, like, what we don't need to make sure they don't need to be as comfortable. But I think that it's important that we continue advocating for appropriate pain medication for our clients. I know my grandma, she was 93 in the last kind of couple of weeks of her life. She was in a lot of pain, fluid retention, and she had a hard time getting a fentanyl patch because it was, right at the height of the epidemic. But, she was in her last couple of weeks of life and deserved to not end this world in excruciating pain. She was able to get it, but just sharing that as well, that perspective. Okay, so here's another question. I think this is Sharon, is this a poll that we have? Did this make it in there?
Yes, this is a poll. Let me see if I can launch it for you.
Awesome.
Here we go. Ready for me to launch it? Here we go.
Yeah. Okay, what is the most abused substance for an older adult? Opioids, alcohol, benzos, marijuana, all of the above.
And I see the answers coming in, so we'll give it a minute.
Awesome.
And Christine,
Thank
don't
you.
forget to move your cursor. We're getting that box again, so sorry.
Okay. There
We're getting the big one that covers.
Yeah, that's cool. Okay,
It's even worse now. Oh, there, it's better. Okay, I still see a couple people responding to the poll. We'll give it another moment or two. And here are the results.
okay. So it looks like opioids 15%, alcohol 50%, benzos 19%, 17%, all of the above. So thank you for participating. Let's see what's the answer. And it is alcohol. Pretty significantly alcohol. So alcohol is the most used drug among older adults, with about 65% of people 65 and older reporting high risk drinking, which is defined as exceeding daily guidelines at least weekly in the past year. 10% of 65 or older are currently binge drinking, which is 5 or more drinks in one setting, which is a significant amount for an older adult to be drinking, for anyone to be drinking, frankly, on a regular basis. So I think that a lot of there are a couple other kind of things happen also during the opioid epidemic. Is there's been a shift of, because it created so much attention, there's been less attention, less noticing of how much people are drinking alcohol. And it still is, one of the most abused and dangerous drugs that we have. So let's talk about that a little bit more. And the other substances, We get a lot of questions about marijuana, especially as it was legalized during COVID in Illinois. We certainly see older adults use it. It's not something that comes across regularly of being misused, at least that we see here, and the statistics kind of show that as well. It definitely is increasing. 9% of adults 50 to 64 reported past marijuana use, compared to 7 in 2012. Not sure what I couldn't find the statistics now post legalization. But older adults that we see that are using marijuana are using it in less problematic ways, usually to manage pain, to manage other, to sleep. Not saying that can't turn into problems, but we don't typically see it being misused in the same way alcohol is. And doctors are still recommending medical marijuana the past year. I had a question about CBD. Well, it was one of the questions that wanted to address is is CBD safe? Is it dangerous? People, especially older adults, take CBD for pain management, for sleep, for other, for anxiety, other things. I couldn't find a lot of information that it's dangerous or counter. The only thing that I found was that we know that CBD can make you more tired, more drowsy. So you want to be mindful of that with older adults, with their increased risk of falls when they're drowsy and if they're on other medications. But I also think, especially with CBD, it's just too early to know. People have been starting to use CBD fairly recently. So I think that it's good to be mindful of what we do know, and just, we'll see as we go forward. But I didn't see too many alarming things, at least that I saw.
I'm just popping on with a question from Peter, if you don't mind taking that now.
Sure, yeah.
Peter said, I could be wrong, but it's shown that after prolonged abstinence from alcohol or drugs, mood and brain functioning can return to more or less normal. Is that correct? And if that's the case, say with alcohol use disorder, would you happen to know what the research shows about how long that would take before your brain functioning and mood return to normal?
Yeah, well, that's a great question, Peter. And the answer is yes. Most of the time, I'd say the majority of the time, the brain and liver are really resilient organs. It does take time. I don't know what the research says about how long it takes, because I think it does depend on so many different factors: how long the use was, what they're doing, if they have other supportive things, if they're doing replacement activities, if they're in a program, how their other nutrition is. So I don't think there's any 2 to 3 to 6 months and then your brain will be normal. I think you're going to see progression over, every month there'll be a little more progression. I know that I did when I worked with a client who drank for a long time, and he really was struggling with brain fog and memory problems. And I think he was about sober for, I think it was about a year before he felt back to his normal. So I think it just depends on a lot of the factors, but I think that's a really important thing to highlight for people when we're working with them, to give them hope, to give them information that your dopamine levels, your body will reset itself so that it can appropriately, feel good in the same way it did before alcohol.
So there's always that vulnerability to relapse, though, right? Is that
100%?
That's because 100%, of the brain.
Yeah.
Yep.
Right. There's always with every not with any change that we make, right? Whether it's going, losing weight or going to the gym or whatever it is, there's always going to be, it's not it's my brain is good, I'm not going to relapse again. It just kind of minimizes over time. It's not as is strong, especially if they have, so you want people to have the hope that your brain will return back to normal and it will feel good again, but to always be mindful of their triggers and making sure that they are being supportive and knowing when to reach out if particularly if they experience a loss, right? Like to know what are your triggers for relapse, loss, trauma, and as we know, those things do increase over age. The liver is also very resilient organ until a certain point, as we know. If once it becomes cirrhotic, it is often like the point of no return. But for many people, it's really kind of amazing how quickly the liver does restore and heal. I've been with clients who've heavy users, and they didn't drink for a month and their enzymes returned back to normal. So it really is incredible. Okay. Any other questions on that, Sharon?
No, not at this time. There was a comment that often seniors live alone, particularly after the death of a spouse. Their alcohol can creep up and it's unseen or unknown. And I'm sorry, there is a question here. What kind of intervention, for example, neighbors or friends, to attempt to, how could neighbors or friends be involved to attempt to ameliorate the situation? I don't know if you want to take that later or now.
Yeah, we'll go after the break. We'll go into more interventions and engagement. So great question. We'll circle back to that. So talking about what a standard drink is, because this is where it's important to offer education, not, because in our minds, I'm sure everyone thinks about a standard drink. I went to South Africa and I did a wine tasting, and their tasting portions were, I think they were like 7 ounces each for 3 pours. So it's important that we make sure that our clients know what is the amounts per the CDC, what they recommend. So a standard drink would be 12 ounces of beer, about 5% alcohol. So that's usually, the light beers. Be mindful of like the IPAs or the craft beers. They tend to be more alcohol content. It's about 8 to 9 ounces of malt liquor that has about 7% alcohol. So about 5 ounces of table wine, which is not that much. If you'd like a little fun game this morning, measure out 5 ounces and just to kind of see what that pour is, because it is less than most people think. And then 1.5 fluid ounce shot of 80 proof spirits. So for an older adult, let's see, I think that's, there we go. For an older adult, the safe drinking limits, 65 and up, if you're not taking any medication or have any other health complications, this is what the CDC recommends. It's no more than 1 standard drink per day. Anything more than that, studies, research has shown it can be harmful to your health. And again, when you're giving this information to clients, this isn't meant to be a scare tactic or be like, you can't, but just give them the information of like, this is what the research shows. So if you are having 2 glasses of wine a day, let's just kind of check in about, at your next doctor's appointment, how are your numbers looking? And maybe we reduce a little bit if they're open to that. There's different, as I started with talking about continuum of addiction, there's levels of drinking, there's levels of use. It's not all or nothing, right? We start with non-hazardous drinking, which is use of alcohol without clear risk of complications, and it does include the beneficial use. So this is for people who are drinking those limits that are defined as them. And hey, I have a glass of red wine at night because I like it with my dinner, it helps me relax, and I don't want that second, and I have no other complications, right? That would be someone who is falling under the non-hazardous drinking. The hazardous drinking would be someone that is the use of alcohol increases risk for complications. So maybe they're having 2 or 3 glasses, they're feeling more impaired, they have vertigo or they have other complications that make balance hard. So that's when the risks increase. And then we have harmful drinking, which is the use of alcohol that causes complications. And that can elevate to then abuse and dependence.
Christine, somebody asked if you could go back just for a moment and show the previous slide with the glass sizes.
Oh, sure.
So that's 12 ounces is a beer, 8 to 9 ounces is in a 12-ounce glass, a 5-ounce pour of wine, and a shot is 1.5 ounces, right? Thank you.
And this is and you can find this on the CDC website.
And we'll share this with you.
Yeah, because it's sometimes helpful to give this to clients as you're talking about this. If anyone has an adolescent, it's also helpful to share that with them as well. But that's a whole other presentation. Signs of withdrawal. So as a caretaker, caretakers, family, clinicians, caseworkers need to be mindful of what signs of withdrawal are, because it can be very dangerous for everyone, but particularly with older adults. The most dangerous thing to withdraw from on your own is alcohol or benzodiazepines. So you can actually, with alcohol and benzodiazepines, if you are a heavy drinker and you quit cold turkey, you are at risk of having DT, seizures, and possibly even death. So it's really important that you're educating your clients that if they are users, that they are not, and they want to stop, that they're not stopping on their own. And so signs of withdrawal of alcohol, the minor, the typical hangover signs, headaches, nausea, vomiting. When you start getting into excessive sweating, night sweats, anxiety, restlessness, high blood pressure, tremors, that's when you need to go to the hospital or call 911 immediately, so that they can appropriately detox you at the hospital. Cocaine, amphetamines, and so the really kind of helpful kind of trick to learn to understand what are withdrawal signs with substances is the withdrawal is the opposite of the intended effect of the drug. So for alcohol, the intended effect, it's a depressant, is going to bring you down. And so what the withdrawal, because your body and your brain is trying to recalibrate constantly, you're going to be feeling more anxious, more restlessness, more irritable. That's why people do report once they've stopped using alcohol, they may feel more anxious. And that's when maybe some medication management, some help from a psychiatrist may be helpful to get through that initial, withdrawal. Cocaine, it's intended to make you feel up, to keep you awake. The opposite is going to be fatigue, insomnia, increased appetite, agitation. Cocaine, you can quit cold turkey. It's not going to be pleasant, but there isn't the same risk level of major complications as alcohol and benzos have. Same with opiates. You will want to die. You will want to feel like you will, but you actually will be okay, or you won't experience the same risks as with alcohol. Opiates, runny nose, nausea, vomiting, just typical worst, I've heard it described as like the worst flu of your life. And it really is really hard and painful. Muscle aches, pains, sweating, diarrhea, fever, insomnia. I would say, even though, you're not at risk of dying from the withdrawals of opiates, because it's so unpleasant, your risk of relapse, and then your risk of overdosing, because your tolerance is low, is pretty high. So especially if you have an older adult who's been addicted to opiates, I really recommend having medication to help with that process, because it's really hard to get through.
And Christine, we had a question.
Sure.
Why does an increase in blood pressure go along with withdrawal? Do we know the mechanism?
I don't know the specifics off the top of my head, but I do know that I believe, because alcohol can reduce your blood pressure, right? Because you're feeling more relaxed. It's a depressant. That the opposite can happen then when your body's trying to recalibrate. So like if you're a heavy drinker, like problem that can exist is that you can have dangerous low blood pressure. So then when your body doesn't have the alcohol in it, it's trying to rebalance itself. So that's what I believe. I don't have the specifics at this point.
Interesting.
I'll have to go back to my biology 101 class. So increased complications with alcohol in older adults. So so obviously we know that any comorbid physical or mental health, we should be aware that there are complications with alcohol. The ones specifically, though, that we want to be very careful about are diabetes. Alcohol does lower blood sugars. So it can, if you're on insulin, it can create too low. So that's really important to know. High blood pressure, heart failure. Again, I don't have the exact mechanics of this, but the research shows these are the health conditions that are most, and I would guess with high blood pressure and heart failure, we know that alcohol is an inflammatory. I would guess that's a big proponent of why those are on there. Liver problems, we know that liver is I think we're all aware of the liver gets overloaded with alcohol and it can't function properly. Osteoporosis, I believe that it's because of the way that alcohol, if you drink too much alcohol, your body isn't able to absorb certain nutrients like B vitamins and I think vitamin D. And I think those impact, and I know those impact, bone health. Memory problems, and mood disorders. So those are the things that you'll want to be cognizant about. Dangerous medications. So when you're going the risks, benefits of older adults, should they use alcohol or not? It's important to go through all their medications, but these ones you really want to be mindful of the dangerous interactions. So acetaminophen is not good. You should not drink on that. It's like a double whammy to your liver. It can create liver failure, really dangerous if you have a client who wants to continue drinking and uses pain medication. It's better. It's still not good, but it's better to use ibuprofen over acetaminophen because it doesn't, although there are risks with that, it's not the same high risk level to the liver as acetaminophen. Aspirin and alcohol, we know, thins your blood. So we certainly don't want to combine those two together. Cold and allergy medicine and cough syrups, those often have dangerous interactions because they can make you very fatigued, lethargic. Sleeping pills, I think that's a given why we shouldn't take a sleeping pill with alcohol. Because we can't, if I'm thinking about it, we can't load up our system on depressants because what happens to that is then our respiratory system is depressed and we can't breathe and our body can't function. Anxiety or depression medicine, some are more, I want to say, acceptable than others to use with alcohol. There's different risks on. It's important to look at the guidelines and talk to psychiatrists about if you have a client, for instance, that is refusing to give up that glass of wine a night, but also struggles with anxiety. It's important that you talk with a psychiatrist or doctor about and being honest with, my client does drink and wants to continue. What's the less harmful one to add to their medication regimen? And be cautious always of herbal natural remedies because, even though they're natural, it doesn't mean necessarily that they're without harm. Certain things like St. John's wort and other type of natural remedies that help with anxiety and other problems can impact or exacerbate the effects of alcohol. Okay, so and we're just almost at break. I just want to get through this next slide. Narcan. This, if you remember nothing else from this presentation, I hope you remember this. Naloxone is a life-saving agent. It's used to reverse the withdrawal of opioid related overdoses. So this is, I can't talk more about this, and why everyone should use it, should educate themselves. But if you're a client who is using opioids, even if it's prescription, if they accidentally overdosed and they use this, or someone administers them, it immediately reverses the overdose, and therefore they will not die. And so this is available at all pharmacies now without prescription. You can just walk in and get it. Of course, Peer Services has some. They are starting to be available at libraries and the CTA stations, particularly the South Side, they're now having Narcan vending machines available. There is a lot of stigma still associated with it, with people thinking, oh, well, doesn't this encourage use? And the answer is, we can't help anyone that's dead, right? And so giving people, empowering people to know how to save their lives and their families' lives is so important. If the client is not, let's just say you're with a client and they are unconscious, they had the signs of overdose, and you did, and you thought maybe they did, and you gave them the nasal spray and it turned out it wasn't, there would be no adverse consequences. So nothing would happen to them. It'd be fine. So there really isn't a risk of using it. There are many trainings. Peer Services does offer them. The Live for Lolly, Chicago Recovery Alliance all offer free trainings. There's also an online training through the CDC that I put down there. So if you just Googled naloxone training CDC, you can find that information. So please make sure that you know how to use it, your clients know how to use it, and caregivers know how to use it. Okay, we're going to take a little break. Let's come back. Let me see, what time is it? I have 9:40. So if we can come back at like, let's do it 5 minutes, 9:45. That's okay. That'd be great.
Christine, if you need to take a break, that's fine, but I don't know if you wanted to try really quick to click more and then see if it says hide floating controls.
Yay, I did. Does it work?
No, actually, it didn't help. Now
really?
It's sort of in the middle. Now it's gone. Now it's gone. Okay, maybe it's good now. I think it's gone.
Is it good?
Yep, take your break. Thanks.
Okay, thank you.
I imagine most folks stepped away during the break, but if you didn't, I just want to thank you again for being here, for being so interactive and present during our training this morning. We're really pleased to have over 150 people attending today. That espresso or latte looks beautiful on her slide. Makes me want one.
I know. I was just admiring that, Sharon. That is the
Right?
most magnificent slide I've ever seen. Look at that design and the swirl and the foam. It
beautiful.
really is. It is.
There's almost nothing I like more than an espresso or a latte too. So beautiful and tasty.
I will give you a tip after the webinar. There is a place not too far from CJE off of Tui that had really nice lattes. I was on there for brunch on Sunday.
So now I think everybody wants to know. You could do a plug.
It's called Savannah's. I believe they have three
Ah.
locations. I looked them up and they're on Lincoln Avenue, 5400. There's another one on Lincoln. There are three neighborhoods. Armitage was the other one I noticed. So yes, it was, latte was the big thing over there.
5400 is on my, Lincoln is on my way home.
It's near Mather. It's just, oh, you know what? It's right across from the Budlong Woods Library. So just
Okay, good tip. Good tip. You see, you come to our trainings, not only do you get excellent practice, knowledge, and wisdom from a pro, but you get these little extra tips like where to get a great espresso.
Yes, exactly.
We're just blathering on, Christine.
Oh, that's fine.
And yes, the bar is gone, so I think that took care of it. Yay.
Thank you. Now I learned something new.
Yeah, and then, Christine, also, I was curious, and I wanted to ask you, as long as we're in the break, if you can share. You said the Evanston Library was going to be opening soon. I am familiar with the living room and Turning Point. I'm familiar with that location. Where is the Evanston living room going to be opening?
Yeah, so it will be right on the campus of St. Francis Hospital, which is, yeah, I'm really excited about it. It's good. So that's on like Ridge and
Howard.
Oh, yeah,
Howard.
right close to the Red Line station. So they said we would be open by January, but they haven't broken ground yet with construction. So I don't think that will happen, but certainly by the spring. And there's going to be obviously drop-in services, but we hope to also have ongoing community service, art therapy groups, 12-step groups, other type of groups. So we're really excited for it.
Oh, that is true. So that's going to be a freestanding brick and mortar.
Yes.
Okay.
Yeah, it's this old bungalow that's on the campus of St. Francis. I'm not sure what they used it for before, but yeah, so it'll be really exciting.
Okay. Yeah, I'm familiar. Sharon, I think you know the location. It's close to CJE.
Yep.
Yeah. Okay. Great.
And with this webinar format, I can't pop the link into the Q&A. I'm not allowed to initiate anything as a panelist in this program today. But if you go to the Turning Point website or the Peer website, Peer Services website, or if you Google living room, I'm sure that there'll be updates on those websites, as well as a list of all the living rooms, which is an alternative to the emergency room for people experiencing a mental health crisis, or it sounds like a substance use crisis as well.
Let's see what time it is. Okay, well, I've got 10:45. Should we I'm sorry, 9:45. Should we go ahead and get started?
Yeah.
Great, awesome. Okay. So welcome back. I know it was a quick break, but I talked too much, so of course I'm off schedule here. I want to share this clip. It's about a 14-minute video clip. It's really important to share because well, I'm just gonna let you watch it and then we'll talk about it afterwards. I do want to just put just acknowledge I don't love all of the language he chooses to use in this. So I just want to be mindful of that, and we'll talk more about that later. All right, and hopefully the sound works.
One of my earliest memories is of trying to wake up one of my relatives and not being able to. And I was just a little kid, so I didn't really understand why. But as I got older, I realized we had drug addiction in my family, including later cocaine addiction. I've been thinking about it a lot lately, partly because it's now exactly 100 years since drugs were first banned in the United States and Britain, and we then imposed that on the rest of the world. It's a century since we made this really fateful decision to take addicts and punish them and make them suffer because we believed that would deter them, it would give them an incentive to stop. And a few years ago, I was looking at some of the addicts in my life who I love and trying to figure out if there was some way to help them. And I realized there were loads of incredibly basic questions I just didn't know the answer to. Like, what really causes addiction? Why do we carry on with this approach that doesn't seem to be working? And is there a better way out there that we could try instead? So I read loads of stuff about it, and I couldn't really find the answers I was looking for. So I thought, okay, I'll go and sit with different people around the world who've lived this and studied this and talk to them and see if I can learn from them. And I didn't realize I would end up going over 30,000 miles at the start, but I ended up going and meeting loads of different people, from a transgender crack dealer in Brownsville, Brooklyn, to a scientist who spends a lot of time feeding hallucinogens to mongooses to see if they like them. It turns out they do, but only in very specific circumstances. To the only country that's ever decriminalized all drugs, from cannabis to crack, Portugal. And the thing I realized that really blew my mind is almost everything we think we know about addiction is wrong. And if we start to absorb the new evidence about addiction, I think we're going to have to change a lot more than our drug policies. But let's start with what we think we know, what I thought I know, right? Let's think about this middle row here, right? Imagine all of you for 20 days now went off and used heroin 3 times a day. Some of you look a bit more enthusiastic than others at this prospect. Don't worry, it's just a thought experiment. Imagine you did that, right? What would happen? Now, we have a story about what would happen that we've been told for a century. We think because there are chemical hooks in heroin, as you took it for a while, your body would become dependent on those hooks, you'd start to physically need them, and at the end of those 20 days, you'd all be heroin addicts, right? That's what I thought. First thing that alerted me to the fact something not right with this story, it was explained to me, if I step out of this TED Talk today and I get hit by a car and I break my hip, I'll be taken to hospital and I'll be given loads of diamorphine. Diamorphine is heroin. It's actually much better heroin than you're ever going to buy on the streets, because the stuff you buy from a drug dealer is contaminated. Actually, very little of it is heroin, whereas the stuff you get from the doctor is medically pure. And you'll be given it for quite a long period of time. There are loads of people in this room who may not realize that you've taken quite a lot of heroin, right? And anyone watching this anywhere in the world, this is happening. And if what we believe about addiction is right, those people are exposed to all those chemical hooks. What should happen? They should become addicts. This has been studied really carefully. It doesn't happen. You will have noticed if your grandmother had a hip replacement, she didn't come out as a junkie. And when I learned this, it just seemed so weird to me, so contrary to everything I'd been told, everything I thought I knew. I just thought it couldn't be right. Until I went and met a man called Bruce Alexander, who's a professor of psychology in Vancouver, who carried out an incredible experiment that I think really helps us to understand this issue. Professor Alexander explained to me, the idea of addiction we've all got in our heads, that story, comes partly from a series of experiments that were done earlier in the 20th century. They're really simple experiments. You can do them tonight when you go home if you feel a little bit sadistic. You get a rat and you put it in a cage, and you give it 2 water bottles. One is just water, and the other is water laced with either heroin or cocaine. If you do that, the rat will almost always prefer the drugged water and almost always kill itself quite quickly. So there you go, right? That's how we think it works. In the 70s, Professor Alexander comes along and he looks at this experiment and he noticed something. He said, we're putting the rat in an empty cage. It's got nothing to do except use these drugs. Let's try something a bit different. So Professor Alexander built a cage that he called Rat Park, which is basically heaven for rats, right? They've got loads of cheese, they've got loads of colored balls, they've got loads of tunnels. Crucially, they've got loads of friends, they can have loads of sex, and they've got both the water bottles, the normal water and the drugged water. But here's the fascinating thing. In Rat Park, they don't like the drugged water. They almost never use it. None of them ever use it compulsively. None of them ever overdose. You go from almost 100% overdose when they're isolated to 0% overdose when they have happy and connected lives. Now, when I saw this, Professor Alexander thought, maybe this is just a thing about rats. They're quite different to us, maybe not as different as we'd like, but, But fortunately, there was a human experiment into the exact same principle happening at the exact same time. It was called the Vietnam War. In Vietnam, 20% of all American troops were using loads of heroin. And if you look at the news reports from the time, they were really worried because they thought, my God, we're going to have hundreds of thousands of junkies on the streets of the United States when the war ends. It made total sense. Now, those soldiers who were using loads of heroin were followed home. The Archives of General Psychiatry did a really detailed study, and what happened to them? It turns out they didn't go to rehab. They didn't go into withdrawal. 95% of them just stopped. Now, if you believe the story about chemical hooks, that makes absolutely no sense. But Professor Alexander began to think there might be a different story about addiction. He said, what if addiction isn't about your chemical hooks? What if addiction is about your cage? What if addiction is an adaptation to your environment? Looking at this, there was another professor called Peter Cohen in the Netherlands who said, maybe we shouldn't even call it addiction. Maybe we should call it bonding. Human beings have a natural and innate need to bond. And when we're happy and healthy, we'll bond and connect with each other. But if you can't do that because you're traumatized or isolated or beaten down by life, you will bond with something that will give you some sense of relief. Now, that might be gambling, that might be pornography, that might be cocaine, that might be cannabis, but you will bond and connect with something because that's our nature. That's what we want as human beings. And I think, you know, at first I found this quite a difficult thing to get my head around, but one way that helped me to think about it is, and I can see, you know, I've got over by my seat there a bottle of water, right? I'm looking at lots of you, and lots of you have bottles of water with you, right? Forget drugs, forget the drug war. Totally legally, all of those bottles of water could be bottles of vodka, right? We could all be getting drunk, I might, after this. But we're not, right? Now, because you've been able to afford the approximately £1 gazillion that it costs to get into a TED Talk, I'm guessing you guys could afford to be drinking vodka for the next 6 months. You wouldn't end up homeless. You're not going to do that. And the reason you're not going to do that is not because anyone's stopping you. It's because you've got bonds and connections that you want to be present for. You've got work you love, you've got people you love, you've got healthy relationships. And a core part of addiction, I came to think, and I believe the evidence suggests, is about not being able to bear to be present in your life. Now, this has really significant implications. The most obvious implications are for the war on drugs, right? In Arizona, I went out with a group of women. I was made to wear T-shirts saying I was a drug addict and go out on chain gangs and dig graves while members of the public could jeer at them. And when those women get out of prison, they're going to have criminal records that mean they'll never work in the legal economy again. Now, that's a very extreme example, obviously, in the case of the chain gang, but actually almost everywhere in the world we treat addicts to some degree like that. We punish them, we shame them, we give them criminal records, we put barriers between them reconnecting. There was a doctor in Canada, Dr. Gabor Mate, an amazing man, who said to me, if you wanted to design a system that would make addiction worse, you would design that system. Now, there's a place that decided to do the exact opposite, and I went there to see how it worked. In the year 2000, Portugal had one of the worst drug problems in Europe. 1% of the population was addicted to heroin, which is kind of mind-blowing. Every year, they tried the American way more and more. They punished people and stigmatized them and shamed them more. And every year, the problem got worse. And one day, the Prime Minister and the leader of the opposition got together and basically said, look, we can't go on with a country where we're having ever more people becoming heroin addicts. Let's set up a panel of scientists and doctors to figure out what would genuinely solve the problem. And they set up a panel led by an amazing man called Dr. João Goulão to look at all this new evidence. And they came back and they said, decriminalize all drugs, from cannabis to crack. But, and this is the crucial next step, take all the money we used to spend on cutting addicts off, on disconnecting them, and spend it instead on reconnecting them with the society. And that's not, essentially, that's not really what we think of. What they did wasn't really what we think of as drug treatment in the United States and Britain. So they do residential rehab, they do psychological therapy that does have some value. But the biggest thing they did was the complete opposite of what we do. A massive program of job creation for addicts and microloans for addicts to set up small businesses. So say you used to be a mechanic. When you're ready, they go to a garage and they'll say, if you employ this guy for a year, we'll pay half his wages. The goal was to make sure that every addict in Portugal had something to get out of bed for in the morning. And when I went and met the addicts in Portugal, it was fascinating. What they said is, as they rediscovered purpose, they rediscovered bonds and relationships with the wider society. It'll be 15 years this year since that experiment began, and the results are in. Injecting drug use is down in Portugal, according to the British Journal of Criminology, by 50%, 50%. Overdose is massively down. HIV is massively down among addicts. Addiction in every study is significantly down. One of the ways you know it's worked so well is that almost nobody in Portugal wants to go back to the old system. And that's the kind of political implications. I actually think there's a layer of implications to all this research below that. You know, we live in a culture where people feel really increasingly vulnerable to all sorts of addictions, whether it's to their smartphones or to shopping or to eating. You know, before these talks began, you guys know this, that we were told we weren't allowed to have our smartphones on. And I have to say, a lot of you looked an awful lot like addicts who were being told their dealer was going to be unavailable for the next couple of hours. And, you know, a lot of us feel like that. And it might sound weird to say, oh, you know, I've been talking about how disconnection is a major driver of addiction. But weird to say it's growing because you think, well, we're the most connected society there's ever been, surely. But I increasingly began to think that the connections we have, we think we have, are like a kind of parody of human connection. If you have a crisis in your life, you'll notice something. It won't be your Twitter followers who come to sit with you. It won't be your Facebook friends who help you turn it around. It'll be your flesh and blood friends who you have deep and nuanced and textured face-to-face relationships with. And I think there's a study I read about from Bill McKibben, the environmental writer, that I think tells us a lot about this. It looked at the number of close friends the average American believes they can call on in a crisis. That number has been declining steadily since the 1950s. The amount of floor space an individual has in their home has been steadily increasing. And I think that's like a metaphor for the choice we've made as a culture, right? We've traded floor space for friends, we've traded stuff for connections, and the result is that we are one of the loneliest societies there has ever been. And yet, Bruce Alexander, the guy who did the Rat Park experiment, says, we talk all the time in addiction about individual recovery, and it's right to talk about that. But we need to talk much more about social recovery. Something's gone wrong with us, not just as individuals, but as a group. And we've created a society where, for a lot of us, life looks a whole lot more like that isolated cage and a whole lot less like Rat Park. But if I'm honest, this isn't why I went into it, right? I didn't go in to discover the political stuff, the social stuff. I wanted to know how to help the people I love. And when I came back from this long journey and I'd learned all this, I looked at the addicts in my life, and if you're really candid, it's hard loving an addict, and there's going to be lots of people who know in this room you're angry a lot of the time. And I think one of the reasons why this debate is so charged is because it runs through the heart of each of us, right? Everyone has a bit of them that looks at an addict and thinks, I wish someone would just stop you. And the kind of script we're told for how to deal with the addicts in our life is typified by, I think, by the reality show Intervention. If you guys haven't seen it, I think everything in our lives is typified by reality TV, but that's another TED Talk. If you've never seen the show Intervention, it's a pretty simple premise. You get an addict, all the people in their life, gather them together and say, if you don't shape up, confront them with what they're doing, and they say, if you don't shape up, we're going to cut you off, right? So what they do is they take the connection to the addict and they threaten it. They make it contingent on the addict behaving the way they want. And I began to see why that approach doesn't work. And I began to think that almost that's like the importing of the logic of the drug war into our private lives. So I was thinking, well, how can I be Portuguese, right? And what I try to do now, and I can't tell you I do it consistently, and I can't tell you it's easy, is to say to the addicts in my life that I want to deepen the connection with them, to say to them, I love you, whether you're using or you're not. I love you, whatever state you're in. And if you need me, I'll come and sit with you, because I love you and I don't want you to be alone or to feel alone. And I think the core of that message, you're not alone, we love you, has to be at every level of how we respond to addicts, socially, politically, and individually. For 100 years now, we've been singing war songs about addicts. I think all along we should have been singing love songs to them, because the opposite of addiction is not sobriety. The opposite of addiction is connection. Thank you.
Okay. So I showed that because it's one of my favorite I don't love his using the word junkie or addict all the time, but we seldom really do talk about how important connection is in treatment, and asking people to give up. Many of our clients who have used drugs or alcohol for their entire life, it's their relationship, it's their support system, it's how it's the replacement for a connection. And we know as we get older, right, that connections can get less, right? People that friends and family pass on. It can be, so many articles and people that share that they feel so invisible as they get older, that really they don't have the level of connection that they once had, and or people don't seem interested in connecting with them. And so it makes older adults so much more vulnerable to substance use disorders because of that. We've had we started an open art studio program, and it is for twice a week. We have, all the art supplies you could want, and it gives led by an art therapist. And I think everyone that's currently in it are older adults, so it wasn't intentionally an older adults art studio, but that's kind of what it ended up being. And the meaning that it's brought these clients, and we do not talk about we don't talk about triggers, we don't talk about cravings, we don't offer psychoeducation during this session. This is just really an opportunity for our clients to connect with each other, to support each other, and learn a new skill, be creative. And the tremendous things that we've seen happen in their recovery based on their increase of connection has been incredible. So I really want to stress that as you're thinking about interventions and evidence-based and what we do to help people, not discounting how important connection is. Okay, so other things that make older adults more vulnerable are substance use. And then after this, we're going to start talking about specific interventions, screening, and ways that we can directly engage in this. So we know increased losses, both with own losses of biomedical, maybe having chronic pain, or just their body and mind feeling, looking different than they were used to. Increased shame over substance use. Imagine if you were a person that, secretly used more alcohol throughout their entire life, and not many people really were aware of it. Imagine being, 72, having some consequences that are coming up, and talking with someone, maybe someone that's younger, maybe a different gender, and admitting this lifelong concern. I mean, it is a lot for anyone to admit that. And I think that not being aware of the power of potential age differential, I think can, even our best attempts at trying to break that down, not creating a safe environment, I think can impact their desire to share that. Biomedical vulnerabilities. We know that as we get older, typically we have increased biomedical conditions that can make us more vulnerable to SUD. Feeling unseen and unheard, isolation. Again, we see this a lot. Alcohol, drugs are a great antidote, right, for feeling unseen and unheard. At least it quiets the mind for that moment. And peer pressure. We know that unfortunately peer pressure exists at the beginning and end of our life, but it's so funny how, and especially these retirement communities, the coffee clutch and cocktail hour, like that is a thing, right? And if I'm just thinking, if you're an older adult and you struggle with substance use and you're in a new retirement community, and the way to meet friends, the way to get in the in crowd at that retirement community might be to attend that happy hour that's happening every day. And so imagine how that might feel for someone who knows they are struggling, that no, this is not good for me, but also isolation and loneliness isn't good for me. So how am I supposed to, what am I supposed to do with that? So as we're shifting now into specific treatment with older adults and best recommendations, I also want to acknowledge that still the research is, everywhere it says limited research available, because I think that the populations that we're least interested in researching as far as mental health and other things are women that are pregnant and older adults. And so there tends to be less research, less studies with this population. But what we do know, both with research and also just with direct practice that we know, is that these approaches really do work well with older adults, being client-centered and choice intensive. And so I think even we've worked with clients who are court mandated, older adults are court mandated. And even though the court does say you need to do this, or you risk incarceration, there's still a choice there, right? And so I think that it's important that clients always feel like they have choices and options, and that you lay them out with them in a respectful way and help them make the decision that's best for them. Harm reduction, again, this isn't people do still have some stigma bias against harm reduction, thinking that when they say it, it means that, anything goes or encouraging use. That's absolutely not. When I talk with clients about reducing harm, I also do ask them about their openness in 12 steps or absence-based models. Have they tried it? What was it like? If a client's never tried it, I encourage them to try it out. Go to a couple meetings. Let's see what you think. It's a great way to build community. If they come back and hate it, we can try something different. But I see this particularly with new, not so much people that have been out of the field, but people who are newly graduated, because I think the curriculum in school is very much teaching about harm reduction, which is fantastic, but they also are missing some methods that have worked really well for people along the years. So thinking of that as choice intensive, and utilizing all methods available to see which one is going to work for clients. Relational approach, we know that I'm a relational therapist, so I think it works well with everyone, but particularly with older adults who maybe they have reduced relationships, maybe their adult children are busy with their own children, their support network has reduced. And so really wanting that connection from another person, and to be seen and heard as themselves, and not as, grandma or in the corner. Collaborative with systems. It's really important that with older adults that we are, with their permission, of course, but that we're connecting, collaborating with parents, with adult children, if appropriate, caretakers, spouses, people that, physicians, that are seeing the older adult, that maybe, like for instance, if you're in touch with the doctor, maybe the doctor noticed something in the physical that the older adult maybe didn't share. Perhaps the liver enzymes were elevated at this physical, and they didn't report back to them. So best practice, with their permission, having a collaborative care team, so that we can make sure that we're paying attention to everything that's happening. And acknowledgement of loss. I know this sounds simple. My predecessor, Fran, was very big into acknowledging and sitting with loss. And it was hard for me to do at first, because there is no solution. There is no, okay, well, if you do this, if we use this CBT exercise, and it really is just being with that person. Because think about in your own life, when you've gone through something really hard, what was not helpful? What wasn't helpful is when you talk to a friend and they immediately went into solutions. Well, have you tried this? Have you tried that? What was helpful is just having someone listen and being with you. And I think that's always remember that, because sometimes acknowledging loss, sitting with grief and loss, feels like you're not doing anything, but you're doing everything. Other best practice for older adults in treatment. Research does show that older adults have better results from longer duration of care. Particularly with substance use, we know that if a person has used substances, have had this relationship with drugs or alcohol for 10, 20, 30, 40 years, they are going to need a longer relationship to help support them through that. It is not going to be a 6-session education on drugs and alcohol and then we're good. Unfortunately, insurance companies have other thoughts about that, but we do know that the longer the duration of care, the better the results. Again, we have so many of our clients in our MAR program our older adults have been with us for a long time. And, we've known that we've now had relationships with them for 10, 15 years, and we've seen them grow and shift into the different stages of their life. And the support that they get, not only from the therapy, but then the groups, the other participants in the Aging Well group, in the art group, the more connection we have, the better that they do in their recovery. Ideal models include diagnosis, management of other chronic conditions, rebuilding support networks, improving access to medical services, improved case management, and staff training, evidence-based strategies for this group. Being mindful of differential diagnoses. So, if your client you've noticed just kind of persisting memory problems, that could be, I wonder if they're drinking more. I know that they do like to have wine at night with their dinner. Maybe they're drinking more and they're having a hard time sleeping, therefore having a hard time with their memory. Could be it. It could also be medical diagnosis. So we have to consider and do the screening to rule out the medical diagnoses, to see like if there is a substance use and or mood disorder. So not all evidence, quotes drug behavior as it's referred to indicates a substance use disorder. So for instance, let's just say you have a client who has chronic pain and they're on a prescription of opioids for it. And they've had it for years, they've been taking it fine. And recently, every month they come back saying, oh, I actually spilled 5 of them. I need help to get more prescription. The next month, same things happen, or I lost my prescription bottle, right? Like that can be seen as drugs behavior, trying to get more medication. What else could be happening? Their pain could be increasing, their tolerance could be increasing. And so while they were taking more, it's because they're not getting the adequate pain relief. And so you want to be careful to really kind of understand, like notice the patterns, and then ask the questions, really use that relational approach, that safe relational approach to understand what can be helpful for them. Some suggested techniques when working with older adult: encourage participation in recovery program. This goes back to connection. It doesn't have to be substance use disorder. It doesn't have to be a 12-step, although if they want to, that's great. But there are lots of different recovery programs, both 12-step based, agnostic based, Christian based, and also other things, right? Like what does the client like to do, right? Like thinking about the things that bring them joy, maybe hobbies, maybe new things they want to try out, and finding together groups, communities in which that they can start connecting with. Depending on the area, senior centers often, have different programs, groups available. So really trying to find a program, a community for that client. And working with them, I can't encourage more of the warm handoffs, help case management in that. Don't just give them a phone number or like check out that website. Like maybe they have difficulty accessing a computer or knowing where to go. Maybe it's hard for them to feel the confidence to make that phone call or show up. I think a lot of this is where this kind of goes against, I guess, what my social work values say but I think doing with in times like this really is helpful. And so utilizing your session to to understand what's helpful for the client, look with them, maybe do some phone calls together. If you have the capacity, visit a program, visit something, to just kind of have that nice handoff with that client until they feel comfortable engaging in that community. Using an interdisciplinary approach, making sure that you're paying attention to potential other medical complications or other things that may be affecting your older adult client. Set realistic goals for treatment. I if abstinence is possible for a client, 100%, that's great. I love nothing more than if clients are like, I tried out this 12-step group. I really like it. And I have a sponsor and now I'm done drinking. Love that. It's not possible for everyone. So if it's not possible for the client, rather than continuing to hammer it down with them, start thinking about what reduced harm will allow, or what they will allow, and set your own goals for treatment, like reset your expectations for your own treatment with them. Nothing is more discouraging than being with a client who you can make the change, can make healthier things, but they just can't reach that. And so really getting the support of colleagues to understand, like, and reset your own expectations for the treatment, because your goals need to be aligned with their goals. Coordinated treatment plan, whenever possible, with patient consent, of course, include family members, friends, to increase support. We know that with addiction and substance use, it's a compartmentalized condition. And so many times, they're only sharing certain things with certain people, keeping other relationships a little distant. And so it's important that you shift to more of an integrated support, so that they feel like they have the support, that people are all paying attention, have the knowledge base to help the older adult. Diagnose and treat additional problems, of course, other mood disorders, like finding out why they're using, why for the increase. We talked about alcohol use disorder, withdrawals, and anxiety being a withdrawal effect. Don't be afraid to talk with the client and their medical provider, psychiatrist, or of a potential anti-anxiety medication or something to get them through that period. Post-acute withdrawal can last for many months for a lot of people, depending on their level of use. So if this is something that the client is going to be struggling with to reduce their relapse potential, think about other things that can just help them get through that initial period. So as we talk about characteristics of the helper, I say helper here, this could be case manager, social worker, counselor, doctor, whomever is helping the client. It's pretty simple. It's not rocket science. It's simple, but it does require a lot of reflection and a lot of support for yourself through this. So number one, non-judgmental and empathetic yet honest. And so we all have judgments. That's okay. So I think being aware and acknowledge your own biased judgments against substance use, naming that with yourself, your supervisor, your colleagues, because it's not wrong. You deserve that space too. But then finding a place of empathy, like, okay, I have a client who, older adult client I'm working with for so many years, and he just keeps relapsing and relapsing and relapsing. He's lost so much, and we've done everything, right? Like, I'm frustrated, and that's okay. Like, it's very frustrating. I need a space to get that out, and then I need to tap into the empathic part of myself that I have. Okay, what is it like for the client? What do I know about the client? How hard this is for him? And then using all of that to be honest with the client. I think it's appropriate to if you have that relationship with the client, to be honest about you as the other relationship in this setting, right? It's really hard for me to watch you continue to harm yourself. Like, I care about you. So it's a skill of using our judgments, maybe our own biases and our care in a helpful way for the client. But of course, you want to do your own work and work with the supervisor on this. So to reduce denial and resistance, use a graduated interview approach about broad substance use. So don't start off heavy hitting, like, do you use heroin, right? Like, that's gonna set the tone for the rest of the screener. But start with the more normalized substances. Caffeine, tell me about your caffeine intake. What about history of nicotine use? So that this is you're looking at this as more of a medical understanding than, are you a drug addict? Yes or no. Engage in dialogue about potential risks and complications, including what they are, if any, safe limits, without giving warnings. So we want to give accurate information, but we don't want to scare our clients. And there's a fine line here because, right, how do we talk about the dangers of withdrawal without scaring our clients? Because it's very scary. Just being mindful in that setting when you are talking about things that are scary, of your approach, the way that you're engaging with the client, making sure that you're not lecturing, you're pausing, asking for questions, asking if that makes sense, how they feel about hearing this information. So setting the stage. Clients are more likely to disclose to counselors who show genuine empathy, avoid warnings, and offer an open, inviting dialogue. I'm always like, when I'm doing research, and I'm like, I can't believe this is actually like, we had to research this. Of course, like, people are more likely to like open up to people who are just generally warm and inviting. Like, that makes sense. I once went to a doctor and they said, oh, I can't help you. And that was I felt so shut down in that moment. And there were so many better ways that doctor could have handled that. So when we're setting the stage, right, and be mindful of our environment. I think environment is also important in how we're talking about these things. Is it comfortable? Are we offering, if the client is diabetic, or even if the client is like food insecure, are we offering things that can help make the client more comfortable? Open with genuine concern on the client's reporting problem and the concerns about use. So, right, we share, if they shared something with you in a session previously, ask them for permission, if something came up in the last session and I'm wondering if we can touch base on that again. Of course, we're ensuring client safety, and we're making them, and clients do feel taken care of, right? My client doesn't always love, I've been with him for a long time. I've had to call a couple of wellness checks on him. He doesn't love that, of course, no one does. But he also really, it felt really, and part of him does like it, right? It feels like someone is watching out for him. He lives alone, that I care about him, and that I am going to do these things if I don't hear from him, because I want to make sure that he's okay. Use the ask, tell, ask approach. I'll talk about that in the next slide, but it's a nice way to ask these questions. If you're nervous about, like, how do I ask my client if they, use drugs or alcohol? Avoid labels. So just what I didn't like in the video is, even referring to a client as, you have an addiction or you're an addict. Everyone uses their own terms, and we have to be mindful, respectful of those terms. Even referring to someone as sober, right? They may have feelings about, like, if they don't use drugs or alcohol, they may not like using the word sober, that they may love using that word. And so I think it's just being mindful about the language the client is using in relation to substance use, and making sure that we are using that. For instance, some of our clients in our MAR clinic, we have to do toxicology screens, urine analysis, to determine the different codes and treatment. It's very old school to call a clean or dirty drop, right? Like, that is what is done in court systems. That's what these clients are used to in treatment settings. I will never use that term when I am talking about it to colleagues, when I'm talking about it, because I think the clean versus dirty drop, it really creates this stigma. But if I'm with a client and that's what they're referring, like, they like the guy had a clean drop this time, right? Like if they're really excited about it, I'm not going to re-educate their language, right? Because I think that can also create a power differential. Like, you know, my younger clinician with a master's degree just told me I can't use this word, right? We don't need to do that. But I think let's be mindful when we're talking to other professionals, when we're talking to other people, that we're re-educating and not putting, you know, bias and stigma in the words that we use.
Christine, I just popped on to say, unfortunately, we only have a few minutes left, but I think we've done a great job of answering the questions as you were going along. So feel free.
Oh my goodness, we are at time. Okay. Can I talk about referrals real quick?
Absolutely. We have a few minutes.
Okay, perfect. All right. That's perfect timing. I somehow had in my mind that we had like 10 more minutes, but let me go here. And I'm going to share this PowerPoint. Please feel free to contact me if you wanted to follow up, if you wanted to talk. I'm more than happy to talk further. So referrals needed. So this is, so the great place to start, I think, is there's fine treatment at SAMHSA. This goes anywhere in the country. You can type in location, insurance, etc. It'll pop up treatment facilities. Please do be mindful of Medicare, Medicaid. Medicare still really is very limited, and particularly the inpatient treatment that it will offer. And so before giving clients numbers, places, you need to do the work beforehand and calling them maybe with the client and asking, do they accept Medicare? If they don't, do they have any kind of state funded beds? Or other scholarship opportunities for Medicare clients, making sure that ask about what the intake process looks like, and making sure essentially that the client feels as prepared as possible for how to get enrolled. So again, I know we're at time. I apologize for not getting to everything today. I share, or someone from ElderWorks will share my contact information in the slides, and please do reach out if you'd like more information. Happy to provide that.
Yes, thank you very much, Christine. We certainly will share your contact information.
This has been just wonderful, and obviously we could use even more of your time, so we'll just have to do this again. Thank you so much for this wonderful, really informative, just basic training on substance use in older adults. It's like a boot camp that I think we all needed to learn some of this knowledge, to feel comfortable in assessing and referring older adults who may be in need of treatment. And thank you so much, Christine, for being so generous with your time and for sharing your expertise with all of us. And I know we've all got a wonderful referral source at you as well. We will share your information. I think an evaluation is going to pop up as people are leaving the webinar. You'll also get instructions on how to, and Karen, I see you're raising your hand, and I'm not sure let me see if I can find a way to let you speak here, but I'm not sure I can do that quickly enough with the time we have. Can you put it in the Q&A if you've got a question? I see a ton of people thanking you and saying, oh, she said it was by mistake. Okay, so I think we're good. We want to thank you all so much for being here. Please do fill out the evaluation, and you need to do so if you need the CEUs or would like the CEUs. And you'll all get the presentation slides as well as Christine's information. Thank you again to JCFS, and also to Peer Services and to ElderWorks. And of course, my own organization, CJE. We all collaborated to bring you this wonderful training. Thank you so much, everybody. Have a great day.